Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. So let me move on, and I'm delighted with all the presentations that we had today because they are very much gearing towards what I wanted to say. Now, I'm just not sure how to... There's a slight change in the photo, but I didn't meant to have the photo of Peter on my landing slide, but doesn't matter. Peter is a very good friend of mine for many years. So I'm going to talk about the cardiometabolic risk assessment and the cardiometabolic risks in people with diabetes. So obviously the concern about cardiometabolic problems is that this is the major cause of death in people with diabetes. Every 6 seconds it's being calculated that one person would be dying because of cardiometabolic related complications. And obviously what we want to do is to try to reduce these problems. The ADA and the ESD have told us that there are 4 pillars for this big problem. One of them is glycemic control, another one is the blood pressure management, and then lipid management, and then obviously it's the cardiovascular data for glycemic targets with specific agents such as SGL2 or GLP-1. But I want to share with you some important information that we have probably neglected. Over the last number of years, we've focused on giving people with diabetes who are at high risk specific classes of drugs regardless of glycemic control. And that's very important. That has a lot of evidence. However, what is also of very important evidence is improvement in glycemic control with any drug is very important because it can reduce myocardial infarction, as you saw from this large study, the UKPDS. And as we saw also from other data, including this Finnish data that looked into coronary heart disease mortality as well as coronary heart disease events. So you can reduce mortality and events in people with diabetes by simple glycemic control as well as with other measures as well. So obviously you all are very familiar with this information, and we're familiar with the cardiovascular risk factors, including physical fitness, obesity, the diet, the hypertension, the lipids. All of these could lead together to the problem of a person having diabetes and cardiovascular disease. Similar to what Riaz have mentioned earlier about the lack of physical activity and the importance of physical activity. This is data from a survey that we've conducted in 12 different countries. Professor Inas is one of the co-authors in it, and we looked into the physical activity as mentioned, as confessed by the people. And of course, we sometimes exaggerate what we do. Nevertheless, only 4% say that their physical activity is high, is intense. And the vast majority are either inactive or low level of physical activity. So clearly, not just in our country, but across the region, from Morocco until Malaysia, the level of physical activity in people with diabetes is very low. This is a study that we've conducted in Dubai as part of the Dubai Household Survey. And we asked people very simple questions. Moderate physical intensity was 10 minutes. 10 minutes spent during routine daily activity, whether at work or at home. And how many people do it every day? Just 10 minutes, 17%. The vast majority are not doing that level of physical activity at all. When you go to slightly higher level of physical activity, of 10 minutes of maybe like playing football or kicking a ball or be slightly more physically active, How many are doing it on a regular basis daily? Only 5%. So clearly, we are enjoying the luxury of sedentary lifestyle. On top of this, unfortunately, our diet has changed. Our classic Mediterranean, Egyptian, or Middle Eastern diet was full of vegetables and full of fruits. Nowadays, it's full of rich carb, fast food, and consequently, when you look into the percentage of fruits and vegetables in the diet of people, in general, this is not just people with diabetes, this is the community of a city such as Dubai, and I can tell you is no different than what I see here as well. So when you look into the numbers of 5 servings a day, whether for fruits and vegetables, you will find that the majority are not having it on a daily basis. So we end up with what? With obesity. And here is the data that we have published, again from the same survey in Dubai, and it's not too different from what we see here. I'm sure if we do similar surveys in Alexandria or Cairo or Egypt in general, we'll come up with more or less the same figures. Only a small number of people, even young people, when you look here into the age group of 18 to 29 and 30 to 33, these are the young people who should be much more physically active and much more with normal weight. But what we see, unfortunately, is we see a lot of people with abnormal weight and overweight and obese, even in young people. So here is the data expressed according to gender, whether men or women. And we thought in the past that maybe people would be looking after themselves because of maybe cosmetic effects. But it doesn't matter anymore. The obesity and the overweight is becoming quite high regardless of the gender. Does this matter? Yes, of course. Both these problems matters very much when it comes to diabetes. Prevalence of diabetes is much higher in obese versus those who are normal weight, and prevalence of diabetes is also much higher in those who are physically inactive compared to physically active. Nearly 3 times the prevalence of diabetes is in those who are inactive regardless of their weight, and this is the data that we've shown and presented in 2017. The data from Egypt is similar. The prevalence of diabetes is very much higher and is getting higher and higher as we get older, and it's not different between men and women, and also a good percentage of people have undiagnosed diabetes. Moving on with another important point, hypertension. And if you look into a cutoff figure of saying what is a diagnosis of hypertension. In this study that we've published last year, we looked into the prevalence of hypertension in Dubai, and the cutoff for diagnosing hypertension, this is not diabetics, this is just the population, everyone. So cutoff of over 140, over 90, that was 32.5%. So nearly a third of the population have hypertension, another third have a blood pressure at the threshold of what you say is of concern between 120 to 140 and between 80 to 90 diastolic. Smoking is becoming a nice fashion. Everybody now goes to the cafe and have shisha, men and women. And it's in the past, when I was young, shisha for women would be a taboo, something like low class. Now it's cool to go and have, we all together and we have shisha. And that obviously is a concern. Obviously, in many data, such as the data in Dubai, women do not confess to being shisha or cigarette smoking. So the data of gender here is a very much underestimation. But nevertheless, look into the data of men. 21% say they are current smokers. So more than 1 in 5 persons of the population in general are smokers. And smoking, of course, smoking and diabetes are very 2 bad companions. So we need to try to do everything. We have developed cardiometabolic guidelines, and we concerned related to the passive smoking. And unfortunately in Egypt, passive smoking is the norm. You do not go to a restaurant and you find this is the smoking area and this is the non-smoking area. No, smoking is the norm. You go to the restaurant, or you go to a cafe, or you go sit in the lobby of the hotel, and you are exposed to passive smoking because there is no segregated place for active smokers versus non-active smokers. So overall, smoking is really one of the problems that we very rarely address and very rarely provide answers for the people who are dependent on nicotine. And it's important that we try to do this. Now to the point that Riaz mentioned about prediabetes. And prediabetes, I'm not surprised at all that in people with prediabetes, they have early signs of neuropathy, because someone have decided that figure is diabetes, that figure is prediabetes. Life is not like this. Life is a continuum. So the person who fails scoring 49% is only 1% different than the person who passed. So obviously it's a continuum, and we need to understand. And when you look into the physical characteristics, and this is data from Wuqaya. Wuqaya is an insurance program in Abu Dhabi, and they looked into data from over 55,000 persons from the community. And as you can see, the profile of the persons with prediabetes is almost identical to the profile of the person with diabetes, with the risks of hypertension, central obesity, dyslipidemia. All of them are more or less the same. Now, what happens when you do not address the risk factors? And this is data from the Swedish register. The Swedish register is the strongest global register for diabetes. They have data on every single person in the country. And as you can see here, if they address the risk factors, regardless of the age, then the failure, the cardiovascular mortality and morbidity is very low. But as in the box in red, if you do not address the problems and you end up with high levels of risk factors, then the rates of mortality, regardless of the age, becomes pretty high. So a bit of reality check. Where are we? Well, you had a photo with Mohamed Salah. Now I have the pleasure of sharing his photo scoring, a very important goal for the Egyptian national team. Reality is, even in institutions with very good resources, I work in the hospital with the university and the government of Dubai, and the resources are there. We are not short of giving the right treatment or providing the right doctors. But nevertheless, those who achieve HbA1c of less than 7% are only 37.7% of our population, which means that 60% or more have an HbA1c above the target. And the problem is not just for HbA1c, it's also for lipids profile. Again, we do not have a problem to prescribe the appropriate statin or other lipid-lowering agents. Having said that, not everyone have the desired target of LDL, and of course, the target is not below 100. The target depends on the risk of the individual. So, I'd like to share with you some of the important information that collected from surveys that we've done for 16,000 persons. What I will show you now is sub-hoc analysis from these data that we've published, one on CKD and the other one on just type 2 diabetes. So this is just hot off the press, got the data 2 days ago. So look into, this is the people with vascular problems. So people with kidney problems, people with cardiac problems, cerebral problems, or foot problems. And this is dissected the data into Gulf, which was mainly data from Saudi Arabia and UAE, or Middle East, which has data from Egypt, Iraq, and Turkey. And as you can see, prescribing of the drugs is very different. Now, you might understand the differences in GLP-1 receptor agonists because they are much more expensive. But for SGLT2 inhibitors, where you should say, and I know that we have lots of generics, where even in the Gulf, so these are vascular persons, so ignore the orange when you say maybe lack of resources. But even in places with good resources, less than 20% are prescribed a GLP-1 and less than 39% are prescribed an SGLT2 inhibitors. So clearly, we are missing for many of our patients. It's not just about the drug. Look into targets. So systolic blood pressure. Systolic blood pressure in this group should be below 130. How many are achieving the target? 34% in Gulf, 21% in Middle East. If you look into LDL, 19% are getting below 55, which is the target for this group. Well, if you want to relax it a bit and you say, let's go to below 70, that's at another 19%. So under 40% are achieving the LDL target in well-resourced places such as the Gulf. And if you look into Middle East, which is Egypt, Iraq, and Turkey, 15% are achieving an LDL of below 70. And honestly, the actual target is below 55. Finally, HbA1c. How many are achieving an HbA1c less than 7.5? Perhaps this group of people have comorbidities and we do not want tight target. So less than 7.5, under 30%, 21 versus 28%. So it's really important that we start thinking and reflect. And I love Aswan as a city where you go and relax and think. I haven't been for maybe 20 years. And we produced the latest cardiometabolic guidelines, a joint effort between the diabetologists and the cardiologists in UAE. I was delighted to be part of this group. And we did this document because we understand that this burden of cardiovascular disease is the main killer. And we also understand that currently things have changed. Everybody is talking about certain drugs, but it's not just about an SGLT2 or a GLP-1. It is about the holistic approach for all of these points. And we also are aware that the vast majority of people with diabetes are not treated by professors in diabetes or consultants in diabetes, by doctors from internal medicine, from primary care, and it's very important to empower them. The time of consultation in many clinics is less than 15 minutes. Someone might say 15 minutes is far too much. It's probably even less than this. So they need to have simple guidance on what to do because the complexity of the assessment is really quite important. I'm not going to give you details of what the guidelines that we've done, but what I want to say is, please make sure that the patient, the person with diabetes, is at the center of the equation. Please assess, and if it's beyond your own capacity, refer. When I was working in UK, me and Mick Kumwanda were working in the same place. We had joint clinics. So Mick would come to some of our diabetes clinics and we will have one of the diabetologists sit in the advanced renal clinic. So sharing our patients, referring our patients early is really quite important. Lifestyle changes is really crucial. Addressing the stress, addressing the appropriate amount of sleep, addressing the physical activity, addressing the smoking, the type of food, all of these points are really very important and they do not cost money. They probably will help to reduce the cost on the burden. My last slide, or possibly the last two slides, when we develop any guidelines, you need to monitor the implementation of guidelines. It's not just about producing a document, no matter how high quality the document is. We need to identify the challenges and the barriers of implementation of any guidelines. We attend lots of conferences. The point is what I'm going home and what I'm going to implement. So my last slide again is the holistic approach of the 4 columns: glycemic control, classic cardiovascular risk factors, the new agents, and of course, above all of this is education. And finally, I'll leave you with the photos of my beloved city, Alexandria. Thank you. And on time.
Yes, on time, as usual.
Thank you.
Any questions?